All right, so today I want to talk a little bit about Lyme disease. And, I'm talking not only as a doctor, but as a former patient. I've experienced Lyme disease myself, as you mentioned in the bio. And so I kind of culminated my experience as a patient, started using it and what I use with my own patients, and found that they started healing faster. So let's jump right into it. So what is Lyme disease? If you're not familiar with this, it's a bacterial infection primarily caused by an organism called Borrelia burgdorferi and other different Borrelia species. In North America, it's mostly Borrelia burgdorferi, and we'll see in just a little bit there are other species around the world that can cause this kind of infection. And most of these infections are transmitted through the bite of a tick called the Ixodes tick, or the Ixodes species. So we discovered all this in the late 1970s. There was this sort of mysterious case of what they thought was juvenile rheumatoid arthritis. All these kids started getting this sort of unexplained arthritic symptoms, and this went on for several years, and nobody could really figure out what was going on. So they figured it was probably some kind of infection. So they started collecting all these blood samples, and they sent it to this researcher at the government named Dr. Willy Bergdorfer. And Dr. Bergdorfer was actually an expert in what's called Rocky Mountain spotted fever, which is a bacteria called rickettsia. So they thought this was some sort of rickettsial infection, and he spent many years trying to figure it out, and eventually discovered a new organism. And the rule is, if you discover the organism, you get to name it after yourself. So his name was Willy Bergdorfer, hence it's called Borrelia burgdorferi. So then, in that early 80s is when we really discovered that, this organism that causes Lyme disease existed. So because it came from Lyme, Connecticut, that's why they called it Lyme disease. We know that there's at least 5 subspecies of Borrelia burgdorferi and at least another 100 strains of Borrelia in the United States. There's more than 300 strains worldwide. We don't even really know how many species can actually cause infection. There's probably at least a dozen, if not more, but there are a lot of these different organisms around the world. In the United States, more than 95% of reported cases really come from New England and the central Midwest. However, California, where I live, is the 5th fastest growing state for Lyme disease in the country. It's been reported in all 50 states. And again, we see it throughout the world. It's an endemic in Europe, in Asia, and in other parts of the world. So in the United States, we get more than 476,000 new cases each year. And in Europe, it's about 90,000. So you can do the math pretty quickly and figure out that these are new cases. So this is probably underreported too. So let's say 500,000 new cases a year. Every year that keeps growing exponentially. So this really has become an epidemic on so many different levels. Transmission, as I mentioned, is primarily through the bite of a deer tick, these Ixodes species. There are other ticks out there. There's wood ticks and dog ticks. As far as we know, those other ticks do not transmit Lyme disease. They can transmit other infections, but not specifically Lyme. There is some evidence that other biting insects may transmit Lyme, things like mosquitoes and so forth. However, there's very few studies. It's not very compelling, because even if they find it in a mosquito, that doesn't necessarily mean they can transmit it to humans. So again, the overwhelming majority of cases are through the bite of a tick. You can get other infections, as I mentioned, through other agents like dog ticks, wood ticks, fleas, mosquitoes, and so forth. And we'll talk in a little bit about why co-infection and not just Lyme disease is important as well. We do have now research showing that there is vertical transmission from mother to baby. If mom is pregnant and has Lyme disease, it's possible that she can transmit it to her unborn child. And from that child is susceptible to either being stillborn, having birth defects, or some element of developmental delays. The big question that comes up is, it's sexually transmitted. To date, there's really only one study that I'm aware of that sort of examined it. Dr. Ray Stricker up in the Bay Area of California looked at semen of men and vaginal secretions of women. They did find, evidence of Borrelia in those secretions, and I think it was like the low 20%. However, they have not shown that it is sexually transmitted. Because the vaginal pH is so acidic, very few microbes can survive that environment. So although it's possible, it's probably not probable. But the truth is, we don't really know the answer because they haven't really studied it. It would actually be very easy for them to do animal studies to do this, but as to date, they have not really investigated it fully. In the United States, we see a handful of strains. Borrelia burgdorferi, we see, out on the East Coast. I say East Coast, I mean, really, we see Borrelia burgdorferi throughout the country, but primarily out on the East Coast. We're now seeing out here on the West Coast, there's a increase in Borrelia miyamotoi, which is often associated with what's called tick-borne relapsing fever. Borrelia mayoni, we see more in the central part of the country. There's Borrelia lone starri and Borrelia hermsii. In Europe, we see Borrelia afzelii, Borrelia greenii. And again, as you go to different parts of the world, the strains do change. So if we look at a map, it's kind of interesting. So if the map on the left there, 2001, is this is from the CDC list of showing what cases have been reported. So all those little green dots are, cases of Lyme disease. So you'll see, again, New England, the central Midwest, you'll see Florida, Texas, and California, and then a few dots in between. And then if we scroll ahead to the next map, which is 2022, you can see a lot more of that green. And you'll see there are green dots in just about every state, including Alaska and Hawaii. So again, this is something that continues to grow over time. It's getting worse. It's not getting better. And this is a map looking at the spread of ticks, these deer ticks. So basically, the map on the left is looking at 1996, the map on the right looking at 2015. So we've got about almost a 20-year gap. And we can see that the spread of deer ticks that used to be, again, mostly confined to, New England, central Midwest, even some parts of Florida, now is kind of pushing in. So we've had at least almost a 50% increase of Lyme disease since 1996. Almost 50% of U.S. counties have established populations of these deer ticks. And we're starting to see a merging of these previously endemic areas. So again, what used to be this sort of localized area keeps pushing in, pushing in, pushing in. These ticks are migrating away from their, what we would say, maybe normal or natural habitat into these other areas. And it's not just Lyme disease. We can look at this map and see that, we've got Rocky Mountain spotted fever, we've got anaplasma, we've got Ehrlichia, we've got Babesia, we've got tularemia. Again, these other infectious agents are also clinically relevant. And clinically, we find that the symptoms of these other infections often look like Lyme disease. So for many people who experience these sort of vague collection of symptoms that people can't really explain, when we do testing, and we'll talk about that in a little bit, not only are we testing for Lyme disease, we're testing for all these co-infections because, again, there's so much overlap in the symptoms that they create. And if we look at a map of Europe, again, we can see that almost all of Western Europe is endemic for Lyme disease. This is from 2017. I apologize, I didn't get a more recent map, but I'm sure that has grown since 2017. This was an interesting study, and this was really looking at the migration of birds, which doesn't specifically relate to Lyme disease. But again, what we're finding is that because of climate change, the fact that the planet's a little bit warmer, birds are migrating further and further away than where they used to go. So what that means is that these ticks can hop on birds, the bird flies somewhere else, lands, that tick can now create a local population in that area. So we think that's a big part of why we're seeing the spread of Lyme disease is that, these birds are now carrying ticks to areas that they didn't used to exist, get a new population, and now it starts to become a problem in that new area. So if you've never seen it, this is what the Ixodes tick looks like. If you ever get bit by a tick and you're not sure, particularly if you live in one of these endemic areas, it's a good idea to go on Google and just kind of familiarize yourself with the difference between a deer tick, a dog tick, a wood tick. Sometimes that can save you a little bit if you do get bit by a tick to know what it is. There are labs out there. If you ever do get bit by a tick, you can send the tick off to the lab. Here in the United States, we use a place called tickreport.com. You can just mail your tick in. They'll tell you what kind of tick it is, and they'll also test it to find out if it carries Lyme disease and any of these infections. But deer ticks are incredibly small. This picture makes it look bigger than it is. An unfed deer tick is about the size of a poppy seed. And even when it's fully fed, it's like a slightly larger poppy seed. So for many people who get by a tick, they don't know, they don't see it. It's very small. I can remember when I lived in Connecticut, I had a tick on my arm. I thought it was a fleck of dirt and I was trying to flick it off, and I started walking it across my skin and I realized it was a tick. So again, they can be very hard to find, and often ticks like the warm, moist areas of your body. So behind your knee, knees, behind your head and your ears, the nape of your neck, your hairline, your armpit, places that people just don't look, don't see. So for a lot of people who get exposed, they actually have no idea they had that exposure. Lyme is the number one spreading vector-borne epidemic worldwide. That means, insect-borne disease. Borrelia can infect any tissue, any organ system. And as a result of that, we see a lot of different symptoms with Lyme disease. There's over 100 different symptoms. And again, often they're vague. They look like a lot of other diseases and can be very easily confused with something else. Borrelia species also can change form. They are true shapeshifters, and they have a slow replication cycle. So most bacteria in your body replicate every 10 to 20 minutes, something like strep throat or staph. Borrelia replicates every 1 to 16 days. The best time to kill any organism or any bacteria is when it's in a replication phase. So the slower the cycle, the longer it takes to treat, the harder it is to treat. There's a reason you can give somebody azithromycin for 5 days if they get strep throat, and it works because it's a very fast replicating bacteria. But Borrelia, because it's so slow, treatment can take much longer. And for people to undergo months of treatment is not uncommon. And again, we'll get more into that later in the presentation. But the fact that the Borrelia can change its shape, Borrelia is technically what's called a spirochete. Spirochete means it's sort of this long corkscrew-shaped organism, and it can be in that long corkscrew shape. It can actually ball itself up into a round ball, what they call a cyst form or a round body form. And then there's also what's called a cell wall deficient or uncoiled filamentous form. So if we look under a microscope, we can actually see it. If you look at this number A here, this is what it looks like in its uncoiled form. It's sort of this long squiggly thing. And then we can see in B, there's some of this long uncoiled, but then you can start to see how it balls itself up into this round body or cyst form. And if we look closer in the C here, you can just see how it kind of winds itself up. This becomes important because when it goes into this round body, into the cyst form, it basically becomes dormant, and the immune system has a very hard time recognizing it. So when it goes in this form, it's almost like it's hiding from the immune system and makes it difficult to see, difficult to treat. It's kind of like, if a cop's looking for a robber and the robber runs inside a house and the cop is just driving by, can't see it inside the house, can't do anything about it. So this organism has adapted to a way to evade our immune system. This sort of adds to the complexity of treatment because, our innate ability to fight infection is sort of compromised when it goes into this form and it hides from the immune system. So what are the symptoms of Lyme disease? I want to kind of break it down into what we call acute Lyme disease and chronic Lyme disease. There's a lot of overlap in the symptoms, but people with acute Lyme disease are typically acutely sick. They feel sick. Headaches, neck stiffness, often very high fever, arthritis with swollen joints, back pain, spine pain, muscle pain. The classic Lyme symptom is what's called an Erythema migrans rash or a bullseye rash, and I'll show you in just a minute. But it literally looks like a bullseye or a target, and that is very classic for Lyme. Unfortunately, very few people actually get the classic rash. So the lack of a rash doesn't mean you don't have Lyme disease, but for people who do get the rash, it's absolute proof that you've been exposed to Lyme. Fatigue, chills, swollen lymph nodes, heart palpitations, shortness of breath, memory loss, and something called Bell's palsy, where one side of your face starts to droop because the facial nerve gets temporarily paralyzed. So again, people like this often, they end up going to the ER, they end up going to their doctor, they feel acutely sick. It almost looks a little bit like meningitis. And often people will go through that whole workup and no, you don't have meningitis. We don't know what it is. But people often, again, have that acute sickness. So this is what that EM rash looks like. You can see it's sort of dark red, then it's light, and it's dark red. And often it starts fairly small. It can spread to be quite big. I know I had an EM rash when I got Lyme disease. It started out about 4 inches. And by the time it got done, it was almost 18 inches. I got bit on the back of my leg. It almost took up the entire back of my leg. And it often will spread over the course of several weeks. Unlike other insect bites, what's kind of unique about this rash is it doesn't tend to be itchy. A lot of insects, when they bite you, like mosquitoes and horseflies and fleas, you tend to itch because there's a histamine reaction. With the Lyme rash, sometimes it itches, but usually it's many, many days after the fact. and it doesn't tend to be raised. A lot of insect bites will have a little raised bump on the skin. This tends to be very flat. If you run your fingers over the skin, it feels flat, it's not raised. So a couple of other things that kind of point that it might be a Lyme rash. Now, there are other rashes related to Lyme that do not look like this. And not to make things complicated, but again, any sort of flat spreading rash that isn't itchy would make me very suspicious of something like Lyme. Acute symptoms can occur anywhere within 3 to 30 days following the tick bite. The CDC says that 70% of infected people get that EM rash, but when you look at the research, it's actually less than 40% of infected people. And for those of us who are in clinical practice, we'll argue that it's probably less than 10 to 20%. We hardly ever see it. Again, for people who do have the rash, we call that pathognomonic, which means there's nothing else in the world that causes it other than Lyme disease. So for people who have that, we don't even necessarily need to go through all the testing. We know they've been exposed, and we would start treatment immediately. But many people end up with these symptoms. Again, they're vague. They resemble other illnesses, other immune and autoimmune diseases. So misdiagnosis is very common. It's not uncommon. People have been to multiple specialists and no one's been able to figure out what they have, but they were never, ever tested for Lyme disease. When it starts to move more into this chronic phase, so for people who get through that initial acute phase, and again, sometimes people don't get that classic acute symptom. It kind of just naturally goes into this sort of chronic symptoms where they're tired all the time. They start having stomach and bowel problems. They have memory loss, we call brain fog, neuropathy, numbness, tingling of the extremities, or sensory distortion of the skin, burning sensations. Migratory joint pain, what that means is one day my right shoulder hurts, then my left knee hurts, then my right ankle hurts. When you start to see this wandering joint pain, again, that's also very classic for Lyme disease. Lighter sound sensitivity, dizziness, vertigo, sleep problems, general muscle joint aches. There is something called Lyme carditis, which causes a bundle branch block in the heart, and people start to have various cardiac issues. Clumsiness, coordination issues. I'll call it newly acquired dyslexia, where people start transposing letters and numbers when they're writing or typing. And then we can start to see hormone problems. Lyme can very much disrupt your thyroid, can disrupt women's reproductive cycles. So over time, this ability to start to change your hormone levels can also be a problem. So you can see just from this collection of symptoms that it's wide, it's varied, it's different body systems. And, if you end up with, stomach bowel trouble, you go to the gastroenterologist. Well, they're thinking it's just a gut issue. They wouldn't really think it was infection. Same thing. You go to the neurologist. Well, it doesn't sound like meningitis, so it must be something else. And this is just a very common scenario that people go from specialist to specialist with no answers. In children, it can look a little bit different. Often it looks a little bit more like mono, which is caused by Epstein-Barr virus. So kids, again, can get fatigue, low-grade fever. They don't tend to get the same high fever adults get. Swollen lymph nodes is common, sore throat, lack of appetite, headaches, joint pain, neck pain, altered gait. You'll start to see kids start to walk a little bit different, mood swings. There's something called PANS, which is pediatric acute onset neuropsychiatric syndrome, where almost overnight these kids develop OCD, anxiety, and tics. Lyme can very much be a trigger for that. Noise or light sensitivity, and then difficulties with memory, focus, concentration. So when you start to see young children having these kind of symptoms that are more kind of older adult type things, again, makes me very suspicious that it could be something like Lyme disease. And again, we call Lyme the great imitator, the great mimic. It looks like a lot of different things. And, autism, MS, ALS, any really kind of neurologic or arthritic kind of symptoms, rheumatoid arthritis, lupus, a lot of these autoimmune diseases, even if that's what your diagnosis is, and you go to the rheumatologist or you go to your neurologist and say, well, okay, why do I have that? They'll say, well, I don't know, bad luck, bad genes. I'm like, well, is it possible that, this infection is a trigger for it? And when we go into the literature, we find that there's a ton of research showing how different infectious agents can trigger autoimmune disease. As your immune system's amping up to fight strep or staph or Lyme, it can accidentally start targeting our own tissue and causing these autoimmune symptoms. We know that with strep, you can get rheumatic fever, rheumatic heart disease. This is well documented, and every doctor in the world knows about this. Well, it happens with other microbes too. It just attacks a different part of the body. So I think for a lot of these neurologic and arthritic syndromes that people don't really have an explanation, again, it is possible that Lyme and these co-infections can be a trigger for those issues. So again, some of these other co-infections, Babesia is a blood parasite that infects your red blood cells. Well, people with Babesia tend to get very high fever. They tend to get this throbbing, pounding headache. They can become anemic because it's affecting the red blood cell. Bartonella is a bacteria that's mostly associated with what we call cat scratch fever, but you can get Bartonella through a tick bite. And burning neuropathy, particularly in the soles of the feet, is very common. Bartonella can also affect the blood vessels. So people with Bartonella often get these look like stretch marks on your body, but it had nothing to do with weight changes. So when we see look stretch marks and people haven't changed their weight, again, very much a red flag for Bartonella. Anaplasma and Ehrlichia can affect your white blood cells. Often people get a very low white count. You can get, fever and joint pain. Mycoplasma is mostly associated with what we call walking pneumonia, but can cause arthritic symptoms. Rickettsia, Powassan virus, other types of viruses. I mean, I swear every time I go to another Lyme conference, we've learned there's, another collection of organisms that can be transmitted through ticks. So again, as we're doing our workup for Lyme disease, often, again, we are testing for these different organisms. It's important to know where you live in the world because some of these things are not really in your area. So we're not always testing for all of this. But again, if you live in Connecticut, we're going to test for one thing. If you live in California, if you live in England, we have to know what's in your local environment because that will dictate what we need to be investigating. Worldwide, again, we're seeing this increase in Lyme disease as well as other vector-borne illnesses. We've seen epidemics of dengue virus in South America, Ebola virus in Western Africa, chikungunya virus in Central and South America, which is now spreading to North America. And again, ticks, fleas, mosquitoes, flies, even snails can transmit these illnesses. World Health Organization published a paper and basically said, we're going to continue seeing all these vector-borne illnesses increase with climate change. Again, the warmer the environment, the more water pools. And so that allows for mosquitoes to be more proliferative. We don't get the cold winters here in the US like we used to. So ticks don't die off in the winter like they used to. So again, the more that these insects can thrive, the greater likelihood they have of spreading the diseases that they carry. So let's talk a little bit about the diagnosis of Lyme disease. This is a bit controversial. And let's kind of get into the weeds of this. So the CDC, the Centers for Disease Control in the United States, criteria was actually designed for surveillance purposes, and they don't actually necessarily reflect active infection. So ultimately, Lyme disease is a clinical diagnosis. It's based on your signs and symptoms, and it's not necessarily based on your lab testing because, again, there's over 100 strains of Borrelia in North America, more than 300 strains worldwide. Really, the testing out there that was developed over 40 years ago really only looks at Borrelia burgdorferi. So if it's not Borrelia burgdorferi, you can imagine it would be very easy to miss it. And knowing that even half the cases here on the West Coast are Borrelia miyamotoi, the test doesn't even look for that at all. So this is directly from the CDC's website, and you can see the Lyme disease diagnosis is based on, first thing, signs and symptoms and history of possible exposure to these Ixodes ticks. Laboratory tests are helpful if used correctly and performed with validated methods, and basically, for people who have symptoms. So the test is kind of validating your suspicion, but it's not the end all and be all about whether you do or do not have Lyme disease. So again, it's just based on that clinical criteria, and the lab test is really there just to, again, validate your suspicion. So the criteria as it stands now is you do what's called an ELISA test. This is a screening test. And if the ELISA test is positive, it will flex over to what's called a Lyme Western blot or immunoblot. And that's a more detailed antibody test looking at IgG and IgM antibodies. So IgM antibodies immunologically are the antibodies that are your first responders to really any infection. And then at a certain point, usually after a matter of weeks or months, then you'll start making IgG antibodies, and that's more of your long-term antibodies. So looking at IgM and IgG gives us an idea about kind of where you are in the process immune-wise and how your body's responded to that infection. So the way we typically think of it, to keep it simple, is IgM shows acute exposure and IgG shows past exposure. And sometimes you'll see IgM and not IgG, you'll see IgM and IgG, or no IgM and only IgG. Again, it just kind of gives us an idea about where your body's at immunologically. So to call this test positive, this Western blot, you have to have 5 out of 10 IgG bands or 2 out of 3 IgM bands, and that's what they consider a positive test. What's fascinating is that in 40 years of research, we know some of these antibodies are very specific to Lyme, some of them are not. But we've never changed that criteria about what we call positive. So why we've never really said, hey, why don't we just look at the ones that we know are specific to Lyme and basically brush off the ones that aren't specific to Lyme? Is that going to give us a better testing outcome? But again, in 40 years, we have not changed that criteria at all. So again, the bands on IgM, they look at the 23, 39, 41. What these numbers actually represent, it's the weight of the antibody. Each of these different antibodies actually weighs something a little different, so they separate it out by weight. But all it really, again, is representing just different antibodies to different parts of the Lyme organism. So 23, 39, 41, you can see with IgG, there's 10 different bands. So again, you have to have either 2 out of 3 or 5 out of 10. Now, if you think about this logically, knowing that some of these antibodies are very specific to Lyme and some of them are not, is it relevant if you have 1 Lyme-specific antibody or 2 Lyme-specific antibodies? In my mind, it's kind of like being a little pregnant, right? I mean, you are or you aren't. If you've got Lyme-specific antibodies, whether it's 1, 2, or 3, what difference does it make, particularly if you've got the clinical symptoms? So again, this is the CDC criteria. There is actually alternative criteria that's been developed by a group called ILADS. That's the International Lyme and Associated Disease Society, where again, it kind of says, hey, even if you've got 1 Lyme-specific band, or you don't have necessarily the same criteria that CDC has, but there's enough evidence from what we do see on the test that we can call this positive. So again, their criteria is a little bit more liberal. Again, equivocal is if you just have 1 band positive if you have 2 or more bands, and same thing with IgG. If you've got 1 or 2 bands versus 5, and positive is really 3 or more. So it's different criteria. And again, I think at the end of the day, us clinicians are really basing it on your symptoms. And again, the lab test is really just to validate our suspicion. So this is an example of one of the labs that I used with a patient I tested. Their Lyme Western blot, they were actually CDC positive on the IgM. So they had on their IgM 23, 31, 34, 41. So that met that criteria. They only had 2 out of 5 or 2 out of 10 IgG. So the IgG was technically negative, or they alternatively called equivocal, but they were IgM positive. So the one thing with these tests is that you don't really get false positives. False negatives are extremely common, but if there's a positive test, it's highly unlikely that there's some other organism that's causing that positive. I've heard doctors tell patients over the years that, oh, that's probably a false positive. I'm like, well, no, I mean, that really doesn't happen. False negatives, yes. But again, if you've got someone who's got the symptoms and you've got this positive test, it kind of makes sense because the two fit. This person also tested positive for anaplasma. So for some of these co-infections too, even if it's only IgG antibodies, you shouldn't have IgG antibodies at all for these things. These are not part of your normal flora. They shouldn't be there. So even an IgG, I think, is relevant about exposure, and we would still treat based on that alone. So you don't necessarily just have to be IgM positive. I think even IgG antibodies are relevant when there's clinical symptoms present. So this is actually a copy of the Western blot, the IgM. So the bottom line here, I apologize, it's not very easy to read, but this is the control, and that top bar, this is actually the patient sample. So they look at how the different bars match up, and they're comparing the intensity of the control with the patient. That's what this box up here represents, it says intensity % of cutoff. This is an older criteria, but their criteria used to be 60%. So there is a threshold set by every lab that you've got to be a certain percentage of the control. So they're measuring quantity of antibody. You can imagine if you're measuring quantity of antibody, what if you only make a little bit of antibody? What if you don't make a lot of antibody? What if your exposure happened months or even years ago? The greater likelihood of picking it up, the longer you get away from exposure, goes way down. We know that immunity wanes with time. So again, one of the pitfalls of this test, again, is we don't know necessarily when people were exposed. A lot of people never saw a tick on them. They didn't pull a tick off their body. So we're often testing probably long after that initial exposure happened. And this is looking at the IgG. Again, this particular person only had 2 antibodies that were positive. That third one here, because it was less than the cutoff of 60%, they called that one negative. This is just another person. They actually were IgM positive for Mycoplasma. They were equivocal for Lyme. Now, this 93 antibody and 34 antibody that came up, these are Lyme-specific antibodies. So the IgM was negative, the IgG, 2 Lyme-specific antibodies, positive IgM for Mycoplasma, IgG positive for Bartonella, IgG positive for Babesia. So this person seems to have been exposed to 4 different microbes. Now, again, this all happened through one tick bite. Was this from other exposure? Unfortunately, these are antibody tests. It doesn't tell us anything about when the exposure occurred. It just shows that they had, and this particular patient had all the clinical symptoms to support that. Again, this is just looking at the IgM. This is someone that just had 41 positive. It was just below the threshold. 41 is a non-specific band. In fact, in this test, 80% of the population has a 41 antibody. So this is a very non-specific antibody. It's a flagellar protein. So because there's other bacteria that make flagella, these are little tails that bacteria have that swim through the body. We'll often find 41 in a lot of people. So that by itself doesn't mean a whole lot. Again, looking at the IgG, this person actually had, now 6 out of 10. So this was IgG positive. So the pitfalls of this test, again, is many people with Lyme disease are seronegative, which means they just don't produce antibodies to the organism, or the amount of antibody they make falls below that threshold. Again, they have to be a certain percentage of the control to call it positive. And I've seen this where, back in the older test, 60% was the cutoff. I would get the results back from the lab. It was 58%, 59%. I mean, that's a function of how much water you drank that day. All these blood tests are a function of blood volume. So how hydrated or dehydrated you are will actually shift your levels a little bit on both sides of the fence. So again, this idea that you have to make a lot of antibody is a bit problematic in these tests. Again, conventional reference labs don't test for the breadth of antibodies associated with Lyme disease. So if you go to Quest and LabCorp, the big reference labs here in the United States, they don't even test for all the same antibodies that the labs that we use do. So again, if you don't look for it, you won't find it. The other pitfall is that, it may take several weeks to make antibodies once you've been exposed. So if you had someone who truly had acute Lyme disease, we have to wait several weeks to even do the test, because if we test you that first week after exposure, you may not have made any antibody yet. So there's nothing yet to test. So if we have someone with acute Lyme disease, or we suspect that, we're probably going to start treatment anyway, knowing that we don't have the ability to test you yet, and we may wait 3 or 4 weeks to do that blood test. The International Lyme and Associated Disease Society, ILADS, again, they have established that separate criteria for diagnosing Lyme. Again, most ILADS doctors are basing it on clinical symptoms, which every doctor should be doing, because that's what the CDC recommendation is, and really using the lab test as a way to help, show what exposures have occurred. Is it just Lyme? Is it co-infection? Is it both? But in that, we also have to rule out other possibilities, because it does look like so many other things. And a lot of these tests come back and they're gray. Maybe they got one antibody. It's not solid. So, we still want to rule out other possibilities to make sure that we're not overlooking something else. And it's, we have to be able to know for sure that we're dealing with Lyme and not some other autoimmune or immune issue. Some of the labs I just want to mention, at least here in the United States, that I use a lot that I think are very reliable. IGeneX out of Palo Alto. They do testing for all Lyme and all the tick-borne illnesses. They have a lot of different profiles where they can test blood, they can test spinal fluid, they can use other body fluids. Like if you drew fluid out of somebody's knee, you could send it to them. I said they're a great lab. They do solid testing. The downside to them is that they only bill Medicare here in the U.S., so they can be quite expensive. If you do a full battery of Lyme and all the tick-borne testing, it could be anywhere from $1,500 to $3,000. So it can be quite expensive. But again, they have great testing. Medical Diagnostic Laboratories in Hamilton, New Jersey also does great testing. They don't have as many tests available as IGeneX does, but again, they do test blood, other body fluids. What I like about them is that at least here in the US, they do bill insurance. Their cash pricing is actually very inexpensive. It's reasonable. So that's the primary lab that I use in my clinic is MDL because, again, I think they do great testing and they're reasonably cost. There's a lab out here in LA called Immunosciences. Dr. Wojani's the medical director there. Again, I think they do great testing. Again, it's cash pricing. It's a little bit more expensive than MDL. But again, these are all good options if we're just trying to help evaluate. I rarely test through a lot of the conventional labs just because we know they tend to miss a lot. The sensitivity of their test kits don't seem to be as good. If you have someone that, you want to run it through that, you can. I mean, there's no problem of running it through a reference lab. And if you get a hit, great. If it comes back positive, again, the likelihood of a false positive is very low. But be aware, if it comes back negative, you might want to still try using one of these other labs just to see if you get different information. There's also a lab based out of Germany called Armin Labs. Armin they do different testing. It's actually a T-cell test, not an antibody test. So I think this can be helpful for especially acute Lyme disease where we're not dependent on antibodies. It's actually looking at a T-cell reaction, and that can happen very quickly after exposure. It's called an ELISpot. And so just be aware, this is a different kind of testing. So again, this can be used as well. And it's just another way to help evaluate someone had exposure. So they do ELISpot for Borrelia and Bartonella and Babesia and so forth. Dr. Richard Horowitz is really one of the, I think, top people in the world on Lyme disease. He's written 2 books on it. He's based out of New York. He actually developed what's called the MSIDS questionnaire. And this has actually been validated in research as an accurate measurement to differentiate people who've had Lyme disease and don't have Lyme disease. And the questions are really geared around neuropathy, cognitive dysfunction, joint and muscle pain, and fatigue. And so I put a link here to the questionnaire. I know this is a slide, but if you just go into Google and type in MSIDS questionnaire, it's a free questionnaire. You can download it. You can score yourself. And again, this has been shown to be a valid tool of assessing weighted Lyme. So if you don't have the ability for whatever reason to do blood testing, and often we'll do this and do the blood test, and again, we'll compare. I also think this questionnaire can be very helpful to monitor symptoms over time, even if you do have Lyme or these co-infections and you're getting treatment. This is a great way to monitor your progress over time because you live in your body day after day. Sometimes it's like watching the grass grow. And again, this can be a more objective way to see how your symptoms are changing over time. I have my own questionnaire that I've really kind of adapted from Dr. Horowitz's questionnaire, only that his is like 3 pages. It's very long. I wanted something that was like short, sweet, to the point. And so this is another questionnaire that's in my book, The Lyme Solution. And again, it's 1 page here, and you can just quickly score yourself and see. Now, I have not done the research with this. This has not been validated in the same way that Dr. Horowitz's has. But again, this is just sort of a quick, easy way to assess, is this something we need to be really suspicious about? People often diagnose themselves on the internet. This happens a lot because Lyme looks like so many different things. Often I have people who come in my practice that are sure they have Lyme disease, and we go through the history, we go through all the testing, and we do find that, again, there are other things. So if you're an internet University of Google scholar, just be careful. And again, it's a good idea to get in the hands of a Lyme specialist that can help navigate whether you do or do not have Lyme before you jump into all the different treatments. Other labs to run that I think are important, and I don't necessarily have to go through all this. Hopefully you'll get a copy of these slides. Again, it's important to look at co-infection. It's important to look at hormones. It's important to look at other metabolic factors, immune factors, inflammatory markers. Again, all of this is giving us information about what the organism has done to your body. Because again, treating the bug by itself is not the totality of treatment. That's part of it. But we need to make sure that we're not overlooking these other things, because often we're treating the organism, but we need to support the immune system. We need to fix the thyroid. We need to reduce inflammation. We need to do all these other things that, Lyme has done to the body. And the best way I can think of it is, if you're standing on the lake in the morning and it's a nice quiet lake and a motorboat goes blowing by, the boat can be long gone, but the waves are still rippling in the wake. And Lyme kind of does to the body. It creates this swath of destruction that even if we're effective at eradicating the organism, we got to clean up the mess. And so these labs can help assess where that mess is occurring.